ethical conversations on prostate cancer. The topic is darolutamide. Our brand name is Nubeqa. So today we will have two speakers. One is Dr. Chanchal Goswami. So he's a senior medical oncologist based at Kolkata, Ruby Hospital, and as well as Manipal Hospital. And in today's evening, our second speaker will be Dr. Chinmay Kumar Padi from Bhubaneswar. Sir is practicing at Utkal Hospital. So I would like to request our first speaker for today, Dr. Chanchal Goswami. Sir, now dice is yours.
Well, am I audible or no?
Yes, sir.
Okay, I'll share my screen then.
Thank you, sir.
Well, is the screen visible now or no?
Yes, sir. Screen is visible.
Okay. So, good evening, everybody, and welcome to this meeting, Dr. Chinmay. So, both of us will be taking the audience through to the data on darolutamide. Now, I'll be speaking the darolutamide data of ARANOTE, that is without chemotherapy, and Chinmay would be speaking on the other data. So, I give my sincere thanks to Bayer for giving us this opportunity to be with you this evening. So my talk is essentially looking at ARANOTE, the evidence of ARANOTE, which is Advancing Metastatic Hormone-Sensitive Prostate Cancer Treatment Horizons, darolutamide without chemotherapy, that is darolutamide plus ADT. That's what we will be looking at. These are the disclosures as per the Bayer company. Now, the standard of care for metastatic hormone-sensitive prostate cancer has evolved to combine ADT with AR inhibitors, abiraterone, or docetaxel. And this has been going on for quite some time, right from 2014. It started with Chartered, where docetaxel was combined with ADT. Then Stampede, where again docetaxel was combined with ADT in the arm C. Then the Latitude, where abiraterone was combined with ADT in 2017. Stampede arm G was abiraterone plus ADT. As you know, Stampede had multiple arms. Then the Archie study, which is enzalutamide plus ADT in 2019. And Enzamet study, which was enzalutamide plus ADT plus minus docetaxel at the same time. Titan, which was apalutamide plus ADT. And then Peace 1, which was abiraterone plus ADT plus minus docetaxel plus minus radiation. This was in 2021. Then 2022 was ARASENS, which brought in darolutamide in the treatment of metastatic hormone-sensitive prostate cancer, and it became a standard of care where darolutamide was combined with docetaxel and ADT. And now in 2024, we have got ARANOTE, which is darolutamide plus ADT, and also we have ARASEC, which is darolutamide plus ADT. Now, despite the treatment with androgen receptor inhibitors plus ADT or docetaxel plus ADT, a large proportion of patients with metastatic hormone-sensitive prostate cancer will eventually progress to metastatic castrate-resistant prostate cancer within roughly a period of 3 years. So there is an unmet therapeutic need, and the unmet medical need remains for an efficacious treatment that offers a differentiated and improved safety profile for patients with metastatic hormone-sensitive prostate cancer without adding significant toxicities and with a low drug-drug interaction potential. Now, darolutamide fits this bill quite well, as you know, because of earlier studies that the drug-drug interaction potential is very low for darolutamide, and it is also a very well-tolerated and effective treatment, which has come from ARASENS, which was a phase 3 study in combination with docetaxel, which showed beneficial efficacy and safety profile in metastatic hormone-sensitive prostate cancer patients, leading to its approval in India in 2023. Darolutamide in combination with ADT would provide efficacy benefit with a favorable safety profile in metastatic hormone-sensitive prostate cancer again, as demonstrated in the global phase 3 ARANOTE trial with a significant portion of Indian patients, which I'll tell you later. And with the ARANOTE data, darolutamide has the potential to change the treatment paradigm, as now it would be the only AR androgen receptor inhibitor who could be used with or without chemotherapy in this segment of patients. So the background is darolutamide plus ADT with docetaxel is a standard of care for metastatic hormone-sensitive prostate cancer, as has been established by the ARASENS study. And ARANOTE was designed to evaluate darolutamide plus ADT versus ADT alone to provide a new treatment options for metastatic hormone-sensitive prostate cancer without docetaxel. Because many of these patients may be elderly and may not be suitable candidate for docetaxel. So we need something without chemotherapy for this group of patients. And so after beyond ARASENS is ARANOTE. This is the study design, which is a randomized double-blind placebo-controlled phase 3 study, where 665 patients were randomized in a 2:1 fashion with to darolutamide 600 milligram twice daily plus ADT versus placebo plus ADT. Metastatic hormone-sensitive prostate cancer, histologically or cytologically confirmed adenocarcinoma of the prostate, ECOG performance 0 to 2. Stratification factors were visceral metastasis, prior local therapy, etc. The primary endpoint was radiological progression-free survival. Secondary endpoints were overall survival, time to initiation of subsequent antineoplastic therapy, time to castrate-resistant prostate cancer, time to PSA progression, rates of undetectable PSA, and time to pain progression, and safety, of course. There were other pre-specified endpoints like PFS2, time to SSE, time to deterioration of quality of life by FACT-P, and time to first prostate cancer-related invasive procedure. They were open-label darolutamide, and there was a 100% crossover to open-label darolutamide once they progressed on placebo. And the selected endpoints were overall safety and overall survival and safety. Data cutoff was June 24, and median follow-up of darolutamide was nearly more than 2 years, 24 months, and placebo also was 25 months. So 25 months, so little over 2 years was the median follow-up. This is the demographics of this patient, and you can see the two groups are pretty well matched in terms of age, in terms of race. There was almost 30% Asian population in both the groups, as depending on the race as well as the region. The ECOG performance score, mostly 50% were 0 and 50% was 1 to 2. Gleason score more than 8 was nearly 70% of these patients in both the groups. PSA median range of was around 21. 2021 was the median range of PSA. Metastasis at initial diagnosis, 70% was de novo, had metastasis to start with, 70 to 75%. And in recurrent patients, no recurrence was there in around 20%. Disease volume, 70% were high volume disease in both the groups and low volume in 30%. Visceral metastasis, nearly 20%, 11 to 12% had visceral metastasis, and 88% did not have any visceral metastasis. There was prior local therapy in 17% of patients and no local therapy in 80% of patients in either of these groups. So otherwise, both the groups were very evenly matched as far as this trial was concerned. If you look at the geographical representation of these patients, you have the Coumadin study, which is the earlier study, which is abiraterone study. Then you have the Vision trial, and you have the EMBARK study. You see, mostly it is American population and some African, Australian, and European participation. But if you look at ARANOTE trial, 30% of the patients were from Asia, 30% from Latin America, Europe, and the rest of the world was around 41%. So that's an important trial, which we can relate as Indian patients and Indian doctors, we can relate to this trial more easily. And this is the APAC region, which is the geographical distribution. You can see almost 14% of from China, 13% from India, around 3% from Taiwan, 4% from Australia, and 2% from New Zealand. So there is a substantial Asia Pacific participation in this particular trial. Coming to the results, this is the radiological progression or reduction of radiological progression-free survival. If you look at the radiological progression-free survival, the darolutamide arm versus the only ADT arm, the median radiological progression-free survival was 70% compared to 52% with the control arm, and the hazard ratio was 0.54. So that was an important achievement at this point of time. If you look at the subgroup analysis for the radiological progression-free survival, everything fell in favor of the darolutamide, starting from the age, the baseline PSA, ECOG performance score, the Gleason score, the disease volume, the race, geographic region, the visceral metastasis, and prior local therapy. So all groups favored the darolutamide in this particular group as far as radiological progression-free survival is concerned. Darolutamide also demonstrated a benefit across all secondary endpoints like time to metastatic CRPC, time to PSA progression, time to initiation of subsequent systemic therapy for prostate cancer, and time to pain progression. Again, all the parameters were in favor of the darolutamide arm, and you can see a good hazard ratio in all of them. So at the time of primary analysis, overall survival data are still immature. Since overall survival is immature, patients will be followed for survival, and all remaining per protocol placebo patients offered to cross over to darolutamide after primary analysis. That is, once they progress, they could be transferred to the active arm. This is the other areas, which is time to metastatic CRPC. Again, the hazard ratio was 0.4 in favor of the darolutamide arm, with the median time to metastatic CRPC was not reached for the darolutamide arm, and it was 13 months for the ADT arm alone. Time to pain progression against the hazard ratio was 0.72, and for the darolutamide arm, it was the median time to pain progression was not reached, whereas for the ADT arm, it was roughly around 29 months, 30 months to be precise, the median time to pain progression. So both were in favor of the active arm, which is darolutamide arm. PSA less than equals to less than 0.2 nanogram milliliter at any given time, any time during treatment, was immensely in favor of the darolutamide. You can see 62% of those patients had PSA levels at almost inconceivable, and the placebo arm had around 18.5%. Time to PSA progression, again, the hazard ratio was 0.31 in favor of darolutamide, where the median time to PSA progression was not reached for darolutamide versus the ADT alone arm, which was around 16.8 months. Coming to the high volume and low volume disease, if you look at it, the blue bars are the darolutamide and the orange bars are the ADT alone. And you can see that the high volume disease had a higher proportion of patients achieved undetectable PSA with darolutamide versus placebo in both the high volume and low volume. Low volume, it was nearly around 70 to 80%. For high volume, it was around 44 to 55%. So substantial patients over a greater period of time, starting at 24 weeks to 48 weeks and any given point of time, they were in favor of the darolutamide. Subsequent life-prolonging anti-cancer treatment, again, patients who discontinued treatment, 45% discontinued in the darolutamide arm, and 70% discontinued in the ADT alone arm. Patients with subsequent life-prolonging systemic antineoplastic therapy was 32% for the darolutamide and 42% for the ADT. And there has been various treatments like docetaxel, abiraterone, enzalutamide, apalutamide, cabazitaxel, radium-223, and olaparib. Incidence of treatment-related adverse event were similar between treatment groups, and discontinuations were lower in the darolutamide arm. As you can see, any AE was almost equal in both the arms. Worst grade AE, grade 3-4, was equal in both the arms, and serious AE was also equal. And treatment-related adverse events leading to permanent discontinuation was 6% in the darolutamide arm and 9% in the placebo arm. The median treatment duration was around 24 months for the darolutamide arm versus 17 months for the ADT alone arm, and the safety profile of darolutamide in ARANODE was independent of PSA response and consistent with favorable tolerability as seen in ARAMIS and ARASEN study, that is the prior two studies with darolutamide. These are the common adverse events were low and similar between the treatment arms. You can see the standard of care. Fatigue was also similar. So there was no difference. We all know that darolutamide is a very well-tolerated drug. And given these elderly patients who have got multiple concomitant medications, darolutamide has very little drug-drug interaction. So it is relatively safe to continue darolutamide in this elderly group of patients. The rate of adverse events commonly associated with the androgen receptor inhibitors were similar across treatment arms, looking at hypertension, vasodilatation, flushing, diabetes, hyperglycemia, cardiac arrhythmias, and so on and so forth. If you look at both the groups, the numbers were very evenly matched as far as darolutamide and the placebo is concerned. Darolutamide also confers a positive impact on quality of life estimation. And as you can see, the hazard ratio was 0.76 in favor of darolutamide, with a median of 16 months for darolutamide and 11 months for placebo. And this is time to deterioration in quality of life, FACT-P. So it took almost 16 months for darolutamide, whereas it was 11 months for ADT. Darolutamide is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression and overall well-being. This is the darolutamide doublet therapy demonstrate clinically meaningful delays in deterioration of overall well-being, especially on social, functional, and urinary symptoms domain. And this is on a FACT-P subscale scores. And you can see everything is onto the left, which is on the favor of darolutamide in this study. So in conclusion, darolutamide plus ADT significantly improved the radiological progression-free survival in patients with metastatic hormone-sensitive prostate cancer. Darolutamide showed a benefit across all secondary endpoints. Darolutamide was associated with a deep PSA response regardless of baseline PSA. Darolutamide is the first and only androgen receptor inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, including social family well-being, functional well-being, urinary symptoms, and darolutamide has a very favorable safety profile. So darolutamide plus ADT without docetaxel should become an additional standard of care for metastatic hormone-sensitive prostate cancer, especially for those where you consider that docetaxel may be a little difficult to execute. So I think darolutamide comes for all metastatic hormone-sensitive prostate cancers, whether you want to use docetaxel or you want to avoid docetaxel. I will stop at this point of time. Thank you very much. If there are any questions, I will take it, and I would request the organizers to continue with the part. I will stop sharing my slides at this point of time.
Thank you, sir. Now I would request Dr. Chinmoy Kumar Panik for the next presentation. And I will request sir to share his slides.
So, am I audible and my slides are visible and it is moving?
Yes, sir.
Slides is moving. I think slide is not moving. Slide is moving,
Yes.
sir.
Yes, sir. It is
Arnav,
moving.
slide is moving.
It is moving, sir.
Okay. Thank you. Thank you. Oh, so thank you very much. Thank you, Chanchal sir, for the kind presentations, and thanks Arnav for giving us the opportunity to communicate with Chanchal sir after a long time. So long time we have not been meeting, and there are many occasions due to the personal reason we could not. So so basically, I'll just Sir has already told detail about the Aranaut, how the new benchmark in the metastatic hormone-sensitive prostate cancer therapy, the impact of darolutamide. I I'll be more thematic than factual, and let me go things one by one. So this is the disclosure, and so already we have been listening this by sir. The point what I wanted to say is that despite the treatment with the AR inhibitor with ADT or Dosi plus ADT, so a large proportion of the patient with metastatic hormone-sensitive prostate cancer will progress, and that number within the 3 year, and that number is quite high. So we have been struggling to find it out that how the docetaxel could be integrated into metastatic hormone sensitive early, or how the abiraterone will be integrated into it. Then we try to figure it out how the generation like enzalutamide and how apalutamide will fit into it, either enza with ADT or the enza with ADT with dosi. And then we have this the Aranaut where the Daru plus ADT, and before we have the Arashan, the darolutamide plus ADT per dosi. So how it has been the impactful. My questions arises one, that how the second generation darolutamide has an impact, and what we wanted to say, what is the silent message we are going to pass, what is the need of darolutamide on in comparison to the Enza plus ADT in the ARCHES trial, or in Latitude the abiraterone plus ADT, or 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 the different phases or the apalutamide plus ADT. So the implications of darolutamide is in its safety, the 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 neurological safety, which is not been given by the enzalutamide. So probably we're exploring that how we can get a strong androgen inhibitor with without any neurological or without any added toxicity in comparison to other things. So then I'll phasing it slow by slow, that how where we're going across. So we have an unmet medical need, and the how the darolutamide in combination with ADT will provide an efficacy benefit with a favorable safety profile, and in the Aranaut, and how it has the potential to change the treatment paradigm. I'll comment on it a little bit later. So darolutamide plus ADT with docetaxel is in standard of care in metastatic hormone-sensitive prostate cancer in RSN, and it has a favorable safety and efficacy. The where the concept come that de-escalation, we are talking about a concept of de-escalation. We have been proven that the escalation may have the benefit, intensification has the benefit, Now we are coming to the de-escalation where we're telling that without chemotherapy also we can manage the patient. But the question is, to whom? Is there a subset of patient or to all? Sir has completely described that how this double-blind phase trial, the within the patient enrollment criteria is metastatic hormone sensitive prostate cancer with an histologically confirmed adenocarcinoma. They have the visceral metastasis, so they are the whether the visceral metastasis is there or not there, or prior local therapy there or not there. They have gone for the randomization, and the primary endpoint as the progression-free survival, and the secondary endpoint was the OS, and the indicator what we see probably this has been included in all the trial, the time to initiation of subsequent angioplasty therapy, time for to CRPC, PSA progression, and what the depth of response like the PSA is 0.2 time to pain progression and safety and the other pre-specified subset, and then it comes to an open label phase that those who are crossover, then 100% crossover seen. So in the selected subset, whether we can get an OS benefit or not, and the point to concluded the data cutoff is in June 7, 2024, and the follow-up time is almost in the range of 25 months. So does 25 months is an adequate time for the follow-up of the patient to opine? Probably answer is yes, will go got from the data and other trials that will say. So perfectly balanced study, Asian group has been included, and more of realistic that the high risk patient they took, where the Gleason score is more than 8 or 70%, almost 69 to 65% are the high Gleason score. So also the PSA is more than 20 is also the high PSA scoring. The important part is that the de novo was 71%, recurrent is 22.4%. So I mean to say, so there are synchronous metastasis and there are metachronous metastasis, I can say. The synchronous people are 71 and 75%. So, and the metachronous people are 22%. There are very high volume disease if you go by the high volume disease criteria. So, by the chartered criteria, the presence of visual metastasis and around more than four bone mates with more than one beyond the vertebral bodies in the pelvis. So it will not localize to one place. It is in the other. So as per the very old criteria, the chartered criteria, there are other criteria, but chartered criteria is one of the very well accepted clinical criteria to opine about. So perfectly told that how the sense subcontinent are there in the 30%, and to more precise, there are the Indian populations also. Sorry, there are 13% patients are from the India. So I think it is truly representative of a regional representative, and so also we can take this data from the Indian perspective, where the abiraterone trial or the enzalutamide trial may not be the Asian component and the Indian component people are not there. So I can say this is one of the trial where the Indian people have been included. 61 patients have got Indian patients are there. So the darolutamide plus ADT reduces the risk of radiological progression, and the placebo arm, it is 25-month median relapse survival, and the darolutamide arm, the median is not raised, and the hazard ratio is 0.54, and in the 2-year period, so 51% in the placebo arm versus 73%, 70% in the darolutamide arm are actually continue to respond. So that's the reason probably why they have taken the 25-month, because the median is almost in the range of the 25-month. And the subgroup analysis, when they try to figure it out, that what are the subgroup, whether it is less than 65 to 74, 75 to 84, and they have included also 29 patients those who are, sorry, 9 patients those who are more than 85. So I can say in a perspective that the look at the age group, and if you look the comparative trials and see the age group, I should say this is one of the appropriate study where they have taken the octogenarian generation people also into the account, which is real fact, as we see more of the patients of the elderly also in the Indian population. And the of good performance status more than one, less than one, Gleason score more than 8, less than 8, irrespective of that, the disease volume, race, Asian geographic area, visual metastasis, prior local therapy, which is almost of 25% have got the prior local therapy. So irrespective of everything, the analysis shows that it has the benefit across the subgroup set. Yes. So darolutamide plus ADT has demonstrated a benefit across the all secondary endpoint. At the time of the primary analysis, the OS data was immature, and the time to CRPC, the median month is 13.8. So another point I wanted to say that why the 25 month is an adequate time period to know the relapse or to know the progression to survival, because the time to CRPC is 13.8. If you go in the other trial also, it is almost in the range of 13 to 15 months. So I think 25 months of follow-up time is an optimal time period to show the relapse may not be of the overall survival, what it shows here also. And time to initiation of the subsequent systemic therapy of the prostate cancer also significant, and the time to pain progression is also with the favors the darolutamide arm. So the OS is immature, and it will be later on it will be published, and remaining protocol placebo patient offered crossover for the primary analysis. That could be one of the reasons why we could not probably interpret the OS data of this. So time to CRPC in the placebo arm, it is 13.8 versus the darolutamide, it is not reached, and the delta is quite significant. The hazard is zero point 0.4. Time to pain progression, the placebo 29.9 month vis-a-vis in the darolutamide plus ADT, the median is not reached, and the hazard ratio is 0.72. So delay in time to progression can be high importance of patient and have not been demonstrated to other androgen receptor inhibitors to date. And the depth of response, that is what is seen in the PSA 0.2 nanogram per ml at the time during the treatment. So I think that is also significant. And the time to PSA progression in the placebo plus ADT is 16.8 versus in the darolutamide plus ADT, it is not written hazard. It's very lucrative hazard, that is 0.31, because it gives an immense confidence, because we are seeing a lot of time period for seeing the PSA progression, because this is the only one thing what we see in the clinical practice in the OPD, that how the PSA is sustainably reduced, and it gain confidence. And so also how the depth of response it actually matters, because if you look into the PSA response, there are a lot of trials to say what should be the ideal PSA response. It should be more than 90% of the PSA declinement. And if you look into the trial, the average PSA value is 20, and you see the PSA value they are putting at any time during the treatment is 0.2. So almost this is 100 times lower, not the 90%. So it is very low. So 100 times lower, I should say. So 63% in the doublet arm attained a PSA of less than 0.2, and this represented a 69% improvement from time to PSA progression in the darolutamide arm versus the ADT arm. And so also it has the impact, though the impact is less profuse in the high volume disease and more profuse in the low volume disease. But irrespective of the volume of the disease, in the both subset, the the response is same. That is the point what I would like to say. The reason why I told because if you look into the doublet versus the triplet arm, and the doublet is preferred in the low volume disease and the triplet is preferred in the high volume disease. But in the iron note gives us a confidence and impression that those people who are not able to take docetaxel, we all know why we cannot give docetaxel. Octogenarian is different comorbidity, logistics, toxicity, so forth and so on, and how this can be an preferred option for them, the subset of people I'm talking about, in spite in irrelevant whether it's a high volume disease or low volume disease, how it can be impactful. And we all know that the subsequent because the patient, those who discontinued and those who took the other therapy, they have a options of giving docetaxel later on. So concept is that, so can we not give docetaxel, and on progression can we give docetaxel, and probably this what they have given. And so in contrary to the other thing, and we have other options also, because we are now going from the era of precision oncology, HRR becoming a norm, which is not there at the enrollment of the trial. And so you have the olaparib along with this medication can be given or not. And abiraterone can be given or not. Ola plus abiraterone data is coming, and so forth and so on. So I think we can explore this armamentarium of choice, which is 5 or 6. If I put the combination, I probably put another 4 to 5 into the armamentarium, whether it is a radium 223, whether it is actinium also, and the what is called the alpha therapy also. We can introduce, and we can put forward the therapy also. So we have already discussed this point, the how the incidence in a situation of the androgen blocker, and what is specifically to this androgen blocker along with the ADT. So probably we are searching for the toxicity in terms of the neurological toxicity, in terms of, because the hot plus the arthralgia and the hot flushes and everything can be with the placebo arm. So it is 7.2, it is 9.2, there is no additional. Then constipation 7.2, so it's not an additional. Increase AST, ALT 7.2, this 9 points, so not much. So almost both are same. The concern part is that, and also you look into the fatigue part also, the fatigue is not also increase. And so I think the if you see the point of concern of the neurological issue, and we look into the mood problem in the darolutamide is 0.4, and the in the placebo plus ADT it is 0.9. So and another important part is the mental impairment, which is 1.6 and 0.5, and the fall is 1.3 versus 0.9, which is not much high. Seizure is not into the not in the column itself, where the seizure is the important part with enzalutamide and less with apalutamide. So the point what I wanted to say, that the complication which probably we anticipate with an addition of the androgen receptor inhibitors, specifically the advanced androgen receptor inhibitor, which have a fear of the neurological consequences, the fear of mental impairment, the fear of a fall, which is actually not there. The safety part is there. The second part is that the cardiology or the cardiac the vascular complication. If we look into the macrovascular complication, so it is 9.5 versus 9.5. This is hypertension. The vasodilatation is 9.2 versus the 7.2. The arrhythmia is 8.8 versus the 6.8. And I think and the one of the uh, remote little bit later complication is the bone fracture, which is 2.3 versus 4. So which is not significant. So the point what I want to convey, that when safety is a concern in the metastatic disease, and toxicity is concerned in metastatic disease, probably we are not impairing the thing which is also presented in the ASCO 25, that the pain progression, overall well-being, has, so it extends the median time to deterioration in the FACT-P total score by the 5.11 versus the placebo. So in the social well-being and in the functional well-being, the prostate cancer well-being, the urinary symptoms, everything has favors the darolutamide arm. So the another, if you go into the ESMO 2025, the update of the Arnaut trial, so they have analyzed into the age-based data, whether less than 65, more than 65, more than 75, and more than 80 they have analyzed, and they opine that irrespective of age, you can give the the darolutamide plus ADT as a sustainable options for the across age group, what I focused before. So to to summarize or to do a comprehensive data set, that darolutamide plus ADT improve the radiological progression to survival in patient with metastatic hormone sensitive prostate cancer, benefit across all secondary point associated with the deeper PSA response, and it's the first and only AR inhibitor to demonstrate meaningful delay in the pain progression, the overall well-being, and the functional well-being, the social and the urinary symptoms with a favorable safety profile. So without docetaxel, the darolutamide plus ADT should become a additional standard of care in metastatic hormone-sensitive prostate cancer, irrespective of the low volume disease and the high volume disease. And so, thank you very much. Thanks, sir.
Thank you, sir, for your wonderful presentation. And now I would like to ask our audience if there is any question. Dr. Shankar Goswami and Dr. Chinmoy Kumar Pami, both our speakers are there. So we are waiting for 1 minute if you have any question.
I think I can discuss with sir also. Chanchal sir, if you allow me, we can talk something. Okay.
Very clear.
So when we feel that we should focus on reducing toxicity, I think that's the point where you uh, need to see that how can the iron out come into the picture, and in the high volume disease, younger age, probably RSN will be the better option because of additions of chemotherapy may give a substantial benefit of the people, those who are having the high volume disease. So high volume disease, younger age, it is RSN. High or low volume disease, elderly, this is RNOT. This is how I place the two trial in place. So Chanchal sir, any opinion from your side? My voice is my voice. Okay. Okay. Thank you, Arnav.
Sir is there. Somehow also.
Arnav,
Sir,
Well, I couldn't hear what Chinmay said because Chinmay's
sir,
voice is not coming properly.
breaking. My
But
voice is breaking, sir. Huh.
I don't know
So,
because there has been
I,
some disturbance with Chinmay's voice. I have seen through the presentation. Both the
yeah.
presentations were similar presentations. I don't know why Bayer made a similar presentation for both of us. Probably if one of us, it would have been better if one of us presented the data without chemotherapy and the other presented the data with
Yes.
chemotherapy. That would have been an ideal presentation, giving the
Ideal
entire
presentation.
spectrum of metastatic hormone-sensitive prostate cancer presentation and the role of darolutamide. But anyway, darolutamide is a good drug, and it's a good drug to stay in this era with metastatic hormone-sensitive prostate cancer as well as metastatic castrate-resistant prostate cancer also. and it's an effective drug. And as I said in my presentation, the best part of this drug is very little drug-drug interaction and a very well-tolerated drug. And it's an effective drug, because the other drugs like apalutamide, then abiraterone acetate, enzalutamide, they are all there, but abiraterone has an inherent difficulty because you need to add steroids to it. Apalutamide is a little more toxic. Enzalutamide is a well-tolerated drug, no doubt about that. But I think darolutamide scores over all these drugs,
True, sir.
except darolutamide is a more expensive drug. So not all patients will be able to afford it. So Bayer has to work out that extra length of mile to see how it can be made more affordable. Okay, Arnav?
True, sir. True, sir. Thank you.
Thank you.
Thank you. Thank you.
Thank you, sir. Sir, I hope there is no question from our audience. So, sir, we are able to complete our meeting today. And in future, we would like to have more meetings from you both. And good night from our end. Thank you, sir, once again.
Thank you. Thank you, everybody. And thank you, Dr.
Thank
Chinmay
you.
Pandey,
Thank you
for a
very much.
wonderful
Thank you.
presentation.
Thank you, sir.
And thank you, Arnav, for giving me this opportunity. Okay. Good night.
Thank you.
Thank you.
Good night, sir.